Okay, so we'll just go over like just the background, non-farms, farms, and then just our general insights, right? Right.
Are there any people watching? Oh my god.
We're gonna record an episode anyway, so whether it's live or not.
There's more than 50 people.
Did you apply to him about the study?
No, not yet. You really want to do it?
You might be upset that you're not gonna show up.
I'll do it like that.
Making shit up. Starting stuff.
You got an email about you get the comment about not the
Alright, it's another one. It's just
you know what, let's start without sending. I think so.
alright, let me just okay, so when we start, I'll count down 3, 2, 1, and then go. I got it. Thanks. The sound was messed up last time because my computer's speaker or my computer's microphone was also picking up our conversation. So the computer.
Oh,
okay,
so
so
you're not
yeah.
muting.
Yeah.
Okay.
So I fixed it.
Right?
Are you ready? Count down.
Are you sure it's recording?
Yeah, we're good. All right. 3, 2, 1.
What is going on, pharmacy people? We are back here for another live episode of Pharmacy Unplugged. As always, we are here to share experience, learn from each other, and take your practice to the next level. This is exciting because this is the first live episode that we're doing therapeutics topic on. So it is somewhat dangerous for us, new territory. So we decided to choose something maybe a little bit simpler, but important nonetheless, right? I say important because if you work in retail pharmacy, you probably have this medical condition. That's right. We are talking about gastroesophageal reflux disease, also known as GERD. So make sure you guys stay tuned until the end. And yeah, exciting, right?
Yes. Sorry, you say most of us have that?
I think so. If you don't have it, that just means that you haven't worked in retail pharmacy long enough. That's how I feel. I don't know. So anyway, before we begin, we want to thank you guys for tuning in and remind you guys how you can interact with us, right?
Yes. As always, our website, pharmacyunplugged.com, is the way to go. All our social media links are there, including our Spotify channel, where all our episodes are, as well as links to our Reddit subreddit forum, where you can post comments on each episode, as well as X. Although I haven't been keeping up on posting there, so I apologize.
That's okay. I don't think people usually interact with us over there anyway, right?
They can send us actually they can send us an email too directly.
Okay.
Do you know our email address?
I don't even know. I should, but I don't.
I set one up.
Okay.
Pharmacyunplugged@gmail.com.
Amazing. There you go. You should type on the chat so people know, right? So yes, come in. If you guys are here, come by and say hi in the chat. And then we would like to interact with you guys more, right? So
Yes.
on our website, you can also find the YouTube link, which will tell you the next episode day and time. It's likely every other Friday for now, 9 p.m. Eastern Standard Time. Okay, so that's pretty much all the background information, right?
Pretty much it.
Yeah. How's your week?
It's all right. It's pretty cold this week.
Freezing, frozen, every single body part.
Yet
frozen.
it was also very busy.
Oh, you're very busy.
It didn't keep people at home.
Oh.
I expected it to be quiet.
It was actually busy for us maybe the beginning of the week and then started dying down. I don't know, actually. I didn't work the last 2 days, so
Oh, look at you.
we'll see. I'll take a look when I go back to work.
You have enough minions now
It's not really minions.
to not work?
Right? Well, I'm not working physically, but I'm still thinking about work, right? So it's like I'm working all the time.
No, you can't get
Right.
away, right?
I cannot actually get away. So it was so cold this week.
Yes.
It's crazy. I know. I was driving here and my ankle was frozen. The water bottle was frozen. It wasn't even defrost by the time like I got off, which was crazy, right? Like frozen.
I have like a zip up my jacket, like hoodie up,
While you're driving?
drawstrings.
While you're driving?
No, I'm walking outside.
Oh, okay.
Well, yeah, when I'm driving as well, I guess. But in the car, I have like the heat pumped up. So once it gets warm enough,
It doesn't
take it
really
off.
matter, right? The water bottle was still frozen. My heat was like up, right? So that was
But
how cold it was.
you rather this freezing cold or you rather snow? It's only one or the other usually, right?
Okay, fine. Freezing cold.
Freezing. Oh, why is that?
Actually, it's hard to say. Snow was okay, except when it starts melting.
That means you're the one that shovels the snow, probably.
I am the one that shovels the snow. But I thought you were gonna ask me if I prefer the cold or the heat, right? Heat, obviously.
Oh, right. Like you mean like summer or winter versus winter?
Yes, of
Okay.
course. No question.
Yeah, that's
I never
okay.
complain about the heat, even though it's like 45 degrees Celsius
Yeah.
outside. But I cannot stand the cold. Anyway, we're here. So what can we do?
So GERD.
Oh, yes. Okay.
Why do we choose GERD? It's because
It's because it's more...
people-
I think it's a simple topic, but important. Because I think most people in pharmacy or like retail will have this issue. I personally do. So it's just stress related, I think.
Yeah, we do see a lot of questions about that, right? Do you think a lot of it has to do with lifestyle, like the American or Canadian lifestyle?
North American lifestyle, you mean? Yes, kind of, right? In a sense, also stress as well, right? Lifestyle is inducing stress right now. So that's causing that unhealthy lifestyle, I guess. That's true.
I mean, we can start with defining GERD. Like, what is GERD? What do you tell patients? Like heartburn, reflux.
It's just
Well-
acid reflux, basically, that's causing discomfort in your stomach, basically, right? It feels like it's tightening. There's like something pressing on it.
Yeah.
That's how I felt, at least, right? And then obviously we go through like the triggers and stuff like that. I don't know, how do you define GERD, like acid reflux? Stomach acid coming back out to
They
your
always point to
esophagus.
their chest, right?
It is.
Like it hurts over there.
Yes, like here.
My
like-
first thought is, are you having a heart attack?
What's the difference, though? Don't they feel like radiating pain if it's like
Yeah,
heart
I
attack?
think there's more signs, right?
Yes.
Yeah, like radiating pain. Some people have radiating down their arm. Everybody
Or
experiences
like
it a bit
chest
differently.
pain on like the chest,
Yeah.
the frontal area, right? Like whatever you call it, pectoral area.
Yeah.
So, but I mean, like personally, because I have experienced stomach acid, so I kind of know if it's not stomach acid, if it's like radiating pain, now like I'm having a heart attack right now, right?
Yeah.
So
So yeah, it's I guess the formal definition: gastroesophageal reflux disease caused by frequent acid reflux. Like you said, basically there's like acid flowing back, right? And there's like a sphincter. Was that LES? Do you remember what that stands for? Like there's a sphincter there, right? That closes once the food enters. It should close.
lower esophageal, right? Yeah.
Lower esophageal sphincter, right. And I guess if that sphincter is not working appropriately or
Or loose.
doesn't tighten or
It's, like,
relaxes
loosened.
too much, the stomach acid comes back up
Yeah.
and causes some burning sensation in the esophagus. And we already kind of alluded to lifestyle factors play a big
Lifestyle's
role.
a big thing. Yeah.
What can you think of in terms of lifestyle? Like, is that the first thing you tell patients when they say, "Hey, I got some heartburn"? Do you go straight to lifestyle, or you're like, no, go straight to this pill?
If they have heartburn, are you talking about like assessing the patient?
Yes.
Which we kind of talk about in like one of the previous episodes, right? So obviously you asked all the background question, right? Okay, so describe the symptoms, right? How long has it been going on for? Have you tried anything? Like those two questions I usually ask pretty much any patients, right? Even if it's counseling on a prescription or like OTC, right? So tell me, how long has it been going on for? Did you try anything? Because if they have tried certain things and if you recommend the same thing, that's like, it makes no sense. You're just like wasting time going through the recommendation, and then they're like, oh, I tried this, which was in the same class of medication, right? So
But I mean, like, do you go straight to the product,
I go to product, yeah.
or do you start with lifestyle? Because for me, I go straight to the product,
I go
and then
product first.
afterwards, I start talking about lifestyle.
Yeah. So go product first, and then tell them, and then we go through like some of the risk factors as well, what you can do to minimize the condition, basically.
But in school, don't they tell you to go non-farms first? Why do we? No, it's always non-farms first, right?
Always non-farm first. Yeah. I mean, if you can treat with non-farms, then great, right? But the patients coming into the pharmacy, they want a product, right? So I just want your opinion. They might not buy the product, but I want to see which one is the best product that you would recommend. You're
not going to spend like 5 minutes going through non-farms before you even go through the medications, right? Because they're going to be standing there listening to you like, okay, dude, I came in to get a pill or something to help me out right now.
I feel like they would react better if you actually tell them the product first and then you go lifestyle, right? Because they're in their mind, they're waiting for the product. Where's the product? Where's the product? Where's the product?
They're not even
He's
listening
not talking
to
about
you.
the product yet, right? So they're not even paying attention to whatever you're saying. All these like, oh, you know, yeah, like caffeine, chocolate, all these stuff. And then they're like, where's the product, right? So they're just waiting. Oh, this is the product. There you go.
Right.
So that's how I approach it. But obviously, it's not wrong to actually go lifestyle first if you want, right? That's fine too. So
should we start with that then?
Do you want to go lifestyle first? Okay, we can go lifestyle. So
it's a big one. Obesity,
yes.
I keep reading that, right? But do you understand why that is?
All these fat compressing on your stomach, right?
Is that what it is?
I think so. That's the same risk factor as like pregnancy, right? The baby
like
compressing on the stomach.
Too much weight on the stomach. Is that what it is?
Yeah, like pushing up on the stomach.
Okay. Oh, pushing up on the stomach.
Yes.
Okay.
So as it's like coming up.
Makes sense.
Yeah. That same reason why pregnancy is a risk factor as well, right?
Right.
So,
right. Like pregnancy, the baby's there, it's taking up room. I guess if you're overweight, your gut's taking up room.
I don't know if we should call it lifestyle. Pregnancy is not really a lifestyle, right? Let's call them like risk factors. These are risk factors, right? Or like what triggers, right? Like triggers, right? Because I can't really call pregnancy a lifestyle.
Is obesity a lifestyle?
Obesity is lifestyle induced, right?
Lifestyle induced, right? Yes.
Lifestyle induced outcome.
It is a result of your lifestyle.
And that's right.
Is it?
Yes.
For most people. We can say for most people.
For most people.
Okay.
Yes. Or medical condition. You can call it a condition.
It could be
right?
medical condition, yeah.
Okay. So let's call it like triggers. Okay.
Okay. So yeah, if you are categorized as obese or overweight, maybe losing weight can help with that. Although this also goes back to if someone comes in, they're overweight, they're telling you they have heartburn, is that the first thing that springs to your mind that you're going to tell them?
Of course not. You tell them the product first, right? So
you give them what they want first, right? And then you go back and then you tell them, okay, these are some other stuff you can do. Other lifestyle factors, I guess. Diet's big. Like overeating, is that one? Yeah.
Overeating, yes. So overeating,
certain types of foods.
Overeating or lying down after eating.
Okay.
Right. Those are like risk factors as well. We talk about overweight, which is pretty much like everything that fits me, pretty much. So
what are you talking about? The overeating?
Overeating. I love eating. I love food.
Yeah.
Yes. Although I don't actually eat that much now.
Are you eating enough?
Meals. I'm eating enough. Yes. I eat like large meals. That's a problem.
Oh, large meals.
Right?
Okay.
Yes, because I eat less frequently but larger meals. So that's possibly a risk factor, and depends on what you eat as well, as you alluded to, right? So the dietary choices, right? So spicy food. I love spicy food. Caffeine, alcohol, I'm not really a big consumer of those. Chocolate.
Fried foods.
Fried food, I love fried food.
Yeah.
Yes. Like spicy, oily, greasy food, fried food, yes. Chocolate, acidic foods.
Yeah, that's all the good stuff.
That's all the good stuff, exactly. So
basically anything that causes your stomach to produce more acid. Is it producing more acid, or those foods itself are acidic? Those foods itself are acidic as well, right?
No, some food is acidic, right? Like maybe citrus, like tomato, and stuff like that. Spicy food is like irritating, I think, right? So I don't really know if they're like all acidic. I don't think they're all acidic though. Alcohol is not acidic. So
yeah, that's true.
Caffeine is not acidic. I don't think it is, at least. So,
but they're commonly cited as like culprits, right? And then we recommend to patients, these are the things that if you're experiencing heartburn right now, perhaps avoid those types of foods for now until you feel better, and then slowly reintroduce if you need to.
Slowly reintroduce? Yes, that's right. Easier said than done though. Like imagine if you tell me no more like spicy food, no more greasy food, I'll be like...
Then you can live with your heartburn.
Then I'll just use...
Or no, we might have some meds for you.
There you go. That's what I want.
Okay, what else? Smoking. Smoking. Yeah.
Okay, smoking. Yes, I don't smoke. So, smoking. What else? We went through like most of the stuff.
Eating
already.
large meals, like
Yeah,
you
we talked
said,
about
and
lying
then
down.
what else did you say? Lying down, right?
Yes. Overweight and obese.
Okay,
Yes.
so should I be eating smaller meals then?
Smaller and more
frequently?
frequent meals. That's the recommendation, right? So,
But
although
isn't the
you're
trend
eating
right now
pharmacy-
to like,
fasting?
yeah, eat less number of meals, right?
Yes, that's
and then you
right.
have a window where you don't eat.
It's good for your blood sugar, right?
Yeah, but then you
Yes.
end up eating maybe bigger meals.
Of course, that's right.
Okay.
So,
So if you have this issue, then maybe that's not a good idea.
I mean, like, it's
Or
okay.
you-
I'll just take PPI.
Is we'll get to that as well, right? PPIs.
So speaking of medication, though, there are medications that could actually cause heartburn as well.
Okay, that's
Right.
a good point.
So mainly NSAIDs,
Mm-hmm.
right? Although I've read that like calcium channel blockers sometimes could cause heartburn as well.
Mm-hmm.
Anticholinergics could cause heartburn as well.
Oh, really?
Yeah, that's what
I never
I've read as well.
Mm.
But NSAID is the big one usually, right? Obviously, like ibuprofen, naproxen, and
Yeah.
so on.
NSAIDs, corticosteroids.
Corticosteroid, that's
That's
right.
a big one.
Hmm.
Calcium channel blockers. I think I read that as well, but it's not part of my counseling point.
Usually not,
I can't think of one where I would actually say that.
because there are more counseling points for those medications, right? Like calcium channel blockers. You're not going to tell them heartburn. That's not like the common one that you want to go through,
first
right?
and foremost.
It's like the other one, like swelling and stuff. Okay.
Okay.
So yeah, some medication induced.
So it could be medication induced,
Mhm.
right?
That's pretty much it for the risk factors, right? Anything
Yeah.
else?
Condition induced. Well, you mentioned pregnancy. Any other conditions?
So we have a comment.
Gastroparesis.
Can some medications mimic heartburn symptoms?
I'll comment in the chat.
Mhm.
Okay. Okay.
Like what?
Bisphosphonates. If it's not digested properly, causes ulcers, right?
Mm-hmm.
That's one.
Mm-hmm. That's right.
That's why you gotta take it with like a full glass of liquid.
Do not
Don't lie down. Go for a walk or something like that
Mm-hmm.
for like half an hour.
So tetracycline also cause like issue as well,
Yes.
right?
All those tetracyclines, we always say take it with plenty of fluids.
Do not lie down.
Yeah.
Yes.
That's actually a good point. We were talking about what conditions.
Mm-hmm.
I was thinking gastroparesis.
Gastroparesis too. Yes.
Can it? Like if you're not digesting your food and it's staying there a bit longer, or the stomach takes too long to empty,
Okay.
I guess it might reflux a little bit back.
Mm-hmm.
It's not emptying basically, right? It's too
Mhm.
full.
Mm-hmm.
You mentioned something earlier. Stress.
Stress. Yes.
How
That's
does that cause
heartburn?
heartburn? I have heard of that, right? Like
It's stress induced. A lot of the
like stress ulcers, or
a lot of the stuff related to gastrointestinal health, which we should talk about in one of the future therapeutic episodes as well,
Mhm.
is actually related to stress, right? Because you also have a lot of those neurotransmitters in your gastrointestinal system as well, right? So a lot of times, symptoms of like heartburn, indigestion, or IBS, right, could be related to anxiety, depression, stress, things like that. So that's what I've read, at least. Right? That's like the newer things.
Do you think stress can also cause like when you're stressed, maybe you end up eating more of that? What would we just say, like chips, chocolate?
To de-stress, right?
Maybe
Yes.
you eat more.
Yes, because those food make you happy, right?
Yeah. So indirectly, that could be causing too.
Yeah. So, but from my experience,
Mhm.
it's very interesting. It's like stress related, which we will share a little bit later. My own experience. Anyway, so we did talk about the risk factors.
Right.
Should we talk about treatment maybe?
I was thinking, we can go to treatment, but it's just going back to like when we're assessing for symptoms, right?
Yeah.
So we said, okay, the obvious one's chest pain, epigastric pain around the center area there,
Yes. So
regurgitation.
sometimes we should talk about how do you rule out other more severe conditions, right? Which would warrant referral, right? So at what point do you say, oh, you need to go see a doctor, or you need to go to emerge, right? So yeah, let's talk about that, like the red flags, right? Okay. So maybe difficulty swallowing, right? So if they have like throat problems, right? So sometimes heartburn can actually manifest as throat problem causing cough as well. I've seen that before. But if they said they actually have difficulty swallowing, that might be like more severe, right? They feel like it's like swollen. Maybe weight loss that's not intentional, right? Like unexplained weight loss.
Okay.
Or sometimes it is persistent, right? Or they have vomiting, let's say, right?
Blood, maybe blood in your vomit.
Blood in the vomit.
If there's an ulcer that's causing that. How about blood in the stools?
Blood in the stool as well. It depends on the blood, right? If it's darker color, then it's more likely that's stomach.
Higher up, right?
Yeah. If it's fresh red color, then it's lower down.
It's right at the anal area. The hemorrhoids, that would be brighter.
Or like polyps and stuff like that, maybe around the rectal or like colon area, right? So that, yeah. So if the stool is like dark red color, the reason is because it has been digested, so it's like dark red, right? Like darker brown, sorry, not dark red, like darker brown color because it's been digested, right? So yeah, we talk about vomiting blood. Can you imagine if you're throwing up blood? You should go to the hospital, right? If I'm throwing up blood, I should go to the hospital right now.
No, I want to visit my pharmacist.
Oh, okay. Yeah. Good for you.
It hurts right here.
And you're like throwing up blood.
Get out of my pharmacy.
So for you, it's easier. It merges that way, right? There you go. So
please step outside to the sidewalk, please. I will call 911 for you while you wait outside.
Don't pass out in my pharmacy.
Okay. So yeah. Yeah, I think that what else would you assess for? Like other symptoms that we mentioned, like I mentioned heart attack. Like we have other signs that indicate it's not as simple as just a heartburn. There's other things that we need to investigate.
So sometimes, let's say if they have tried treatments before and it's not responsive, right? So let's say they try treatment for a period of time and it's not working at all, right? So it could be something a little bit more serious as well. Yeah, so those are the things that I can come up with. Do you guys have anything else?
I have a comment here. Unexplained weight loss and night sweats.
So
okay.
What else we talk about? Night sweats. Okay. Yeah. So any symptoms basically that's not really explained by...
Entirely explained by
the condition.
Right.
Right? Yeah.
I guess the non-pharms that you recommend would just address those lifestyle things then, right? Like, avoid those trigger foods. Chocolate, spicy foods, caffeine, things that we mentioned. Non-pharms, eating smaller meals, we already mentioned. Weight management. What else? What other non-pharms are there?
Non-pharms? Oh, you can apparently you can like prop up your pillow a little bit as well. Like increase the heart rate, right? So elevate, that's what they call, right?
I read somewhere where it's like it's not as simple as elevating the head, which I always thought was what we need to do. Like when I studied in school, it's just like, just put like a little pillow right underneath your head. But that's just your head moving up.
I mean, it does work a little bit as well because you're like inclining, right? Like the inclination probably would work by gravity. I
read you have to put like maybe blocks like underneath the bed. Like you want an angle on your body essentially.
But to be honest with you, if you ask me to like elevate my bed even by like a few inches, I don't think I can sleep that well, right? Which we talk about
That's
maybe
strange,
on the
right? Yeah.
maybe we refer to it in like the sleep episode as well. Because we are very particular about how we sleep, right? Some people wear like eye mask and whatever. Imagine if you have to elevate your pillow by like 10 inches. I was like, how am I going to sleep? My neck would be like sore.
Like unless you have one of those like hospital beds that can recline.
I would not want to, like I can't sleep in like recline bed, right? So
you ever tried?
No, but like sometimes you fall asleep in the couch and you just like get back up again, right?
Yeah.
I'm like I can't sleep.
It's not good sleep.
Exactly. So
smoking cessation, we mentioned.
Weight loss, right?
Managing stress. How do you manage stress then, other than
working
eating
less
what
in the pharmacy?
Like? Working less. Okay,
there you go.
Very good.
Very good, right?
Don't work as much.
Don't work as much. There
but won't you stress about the money then?
That's right. So stress is unavoidable. That's the conclusion today. So what else? Let's see. Don't lie down.
Meditation.
Meditation is good too. Yeah.
Did you say don't lie down?
Don't lie down after eating. Yes.
Oh, after eating. Okay.
Yes.
I thought you meant in general.
No, I have to lie down when I'm sleeping, or like no. Don't lie down after like maybe a couple of hours after eating.
Yeah, let allow time for your body to digest the food.
Don't eat right before going to bed. Right, that's what it is. Okay.
I used to
So
love doing that when I was young.
I didn't
know?
love doing it, but I was doing it based on the lifestyle, because you remember when we're working until midnight, right? I
Yeah.
have to eat, right? Because I don't eat during shift usually, right? I don't have time to eat.
You're hungry after.
Exactly. So I get food, and I get home. It's like 1 p.m.
Yeah.
1 a.m. And I'm eating, right? So, and then afterwards, I cannot stay up for too much longer. So I go to bed at 2. And there you go. Maybe that lifestyle has developed heartburn for me over a few years, possibly.
Do you think when you're younger, though, in general, you're more, your body's better at like fending off things like this, any kind of ailment?
Yeah.
Because I remember eating right before bed too, and like doing midnight shifts, right? It never bothered me. Like this isn't like when we're in our 20s, right? Maybe early 30s.
It sounds so tragic. Like the way that you're like talking about this, so depressing, so depressing, so tragic, that it's like we cannot eat before we sleep anymore. Now that we're so old, it will just get heartburn. if we do
That's
that.
right.
It's true though.
Or you have a pill for that, which we will get to.
That's right. The pill is coming. So hold on. So we did non-farms, right? That's pretty much most of non-farm, right?
That's pretty much it.
We talk about weight loss, right?
Talked about medications, that medication-induced conditions. Should we go to the pills now?
Okay. But
OTCs?
I do want to say something about the non-farm as well, right?
Okay.
So a lot of these things, whenever we're counseling on non-farms, lifestyle factor and stuff like that, easier said than done, right? So that's from my own personal experience as well, right? So imagine if you asked me to like lose weight, like, oh, you should lose weight, like lose 10 kilo or whatever, right? Yes, I know that's what the textbook says, but it's actually hard to do, right?
Like when you're telling someone to, first of all, I guess approaching the subject, depending on the person, they might be sensitive to that, right?
Or even like any non-farm, right? Like exercise more, lose weight, eat healthier, or like don't eat so much spicy food.
Everyone's heard that before.
Right, exactly.
Right.
Right. So like it's very hard to change lifestyle. That's the point that I'm getting to, right? Like you can tell me like, oh, don't eat so much greasy food and stuff like that, but that's my lifestyle really. Like it's hard to change.
Yeah.
Right. So no, I just want to bring that up as well.
Right.
So
like if we're looking for an immediate solution, we're saying lifestyle is they're good recommendations, but that's over a period of time.
I would always think of lifestyle as like supplementation.
You mean like supplementation to medication?
Yes, right?
Okay.
Because medication is like I look at it as like a quicker fix maybe.
Yeah.
Right?
Quicker fix, but in the long term, eventually, if you can correct the lifestyle,
but
then you don't need the medication.
Exactly. So sustainability, maybe you look at like lifestyle. So okay. So that's, we talk about all the lifestyle and stuff like that. We can talk about the pill that we are waiting for.
Oh, is it just one pill? Just one pill?
No, the pill.
Oh, the pill.
Okay. So what pills are we talking about here? So the patient comes in and they look for any like medication, your recommendation. So what are types of medication that we could actually recommend?
So usually, I guess I start off with asking them, like, describe your heartburn. Like, is this something that is occurring all the time? Or is it something that occurs occasionally when you eat certain types of food? And if it is that, if it's something that, okay, you know, when I love spicy food, say, and then whenever I have that, whatever, bibimbap, extra spicy, then I get all these symptoms, but I can't stop eating it because I love it. Then maybe I'll go with an antacid. Right? It's quick, short-term relief.
Okay.
Not something that you have to take every day. I guess we can start with that.
Yeah. So that's the most basic one, right?
Yeah.
So usually, like, for example, Tums, right? Calcium carbonate. That's the most common
That's
one.
the only one I see now.
Yeah.
Wasn't there like, what else was there before? I see Tums all the time now. Rolade. There used to be Rolades, right? But do you see that anymore?
No.
What happened to them?
I don't really know. They were
But
like,
you remember Rolades?
yeah. Like in like small quantity as well.
Yeah.
Like very popular, right?
Do you what do you carry? Like, because
Tums.
our shelves is just Tums.
Tums.
All different strengths and all different flavors.
There's Gaviscon.
Oh, Gaviscon. You know what? Gaviscon, I never really looked into all the ingredients that are in there. Because then it's like, what is it? Like an alginic acid?
It has alginic as well.
Yeah.
Yeah.
And then I'm just like, okay.
Which helps coat the stomach a little
Right.
bit, actually might help a little bit better. So they're in the same category, really.
But they also have antacids, right? Mixed into it?
Yeah. So
Some
it
of them.
works faster, right? Like quicker, like you said, short-term relief. So that's antacid, right? Most common, obviously, calcium. And let's move to the next category before we come back and talk about maybe side effects of these ones.
Sure.
How about that? Okay. So if you want something a little bit stronger, then you move to the H2RA, right?
When would you move to that?
H2 receptor antagonist. I don't know about you, but like, I mean, like I usually start with that. That category. I mean, like just from personal experience. I don't even follow the label instruction. I just like multiple pills at the same time. When Zantac was around.
Did you say multiple pills at the same time?
Yes. Zantac,
what do you mean?
Zantac 150, right? I just take like 2 of them at the same time.
Oh,
so,
okay.
Right? So
I thought you meant multiple classes at the same time.
No. I'm not that intense.
Papa Tums, Papa Ranitidine.
I tried Tums. Tums is okay, right? It tastes pretty good. But I find
calcium
that the,
carbonate, right?
Exactly. So I find that the H2RA works a little bit better. So the ranitidine, although it's not really available now over the counter, right?
There was a big notice of recall, right?
Yes, because it's causing cancer.
Carcinogen.
Exactly. Imagine all this Zantac that I was taking in my stomach. That's not good. But now
don't think about that too much.
Well, I can't do anything.
Did it help your heartburn?
It did help my heartburn.
Okay, that's all you need.
There you go.
Yeah.
Okay. So now there is Pepcid, right, which is famotidine.
Famotidine, yeah.
That's right. Higher strength you can get prescription as well. Ranitidine you can actually still get. You can get prescription because the bottle is like humongous. You can still dispense it. Although I don't think doctors really prescribe it. It's probably because of the recall and everything.
Yeah, it has like a bad rep now.
Yeah. So although I don't think the ones that we keep stock bottles would have any issues, right? Because it's like a different brand, like generic.
I think the ones that are still available, they've worked it out that those ones are okay. Doesn't contain what is it called? NMDA or something like that. NDMA. It sounded like an illicit drug, right? So
Pepcid, we have a comment. That's good. Yeah. So Pepcid is pretty much the only one that's like available now over the counter, right? So that's H2RA.
Okay, so before we go on, actually, so why is H2RA a step up? Why are we saying that? Is it like the mechanism? Why is it better? Like antacids, we say it's pretty direct, right? It counters the acid, the pH, I guess, right?
But it doesn't stop the acid from being produced as much,
right?
Right. So H2RA would decrease the acid being produced a little bit better than antacid. Antacid is almost like, sure, I'll let the acid come and I'll just take something to neutralize the acid.
Right.
Right. So it's like take something basic to actually neutralize the acidic environment, right? But H2RA works a little bit better because it does decrease the acid a little bit more, right? So yeah, that's why I think it works better.
Whereas H2RAs, they actually block, so they block histamine receptors, right?
That's right.
And that reduces the amount of acid that's produced by the stomach, which leads us to our next class. Also reduces the amount of acid that's produced. Our proton pump inhibitors.
The gold standard.
Gold standard.
That's right.
So stronger acid suppression than H2RAs. Available OTC now. For a while, when we first graduated, it wasn't. Or available behind the counter, I should say.
Counter, yes.
Without prescription. For like, up to 14 days or something.
Have you seen omeprazole? Like over behind the counter? I haven't seen it for a while now.
We carry Nexium.
It's only Nexium right now, right?
Yeah.
We used to have omeprazole as well, right?
Might be.
I don't think it's available anymore. Like long time ago it was. When it first became non-prescription, it was both, right? Omeprazole and esomeprazole.
Was it both?
Yeah, it was both. So, but I haven't seen it in a while. So long that I don't even remember the brand name that they have anymore.
I just have Nexium, like just that yellow box.
Yeah, now it's only Nexium.
Right.
They don't make the omeprazole over the counter anymore. Yeah.
That's interesting. But why do we say this one's a gold standard?
It works the best.
Evidence shows it works better than H2RAs, right?
Yes.
Yeah.
Yes, but it works slower. So usually like half an hour to an hour.
Right.
That's from my personal experience.
So when we're actually counseling, and we can go into more detail later on, that's part of the counseling point, right? When should you take a PPI? Versus an antacid, you can take it if you have heartburn right now. You can take it right now. Neutralizes the acid. You can take it before too if you want.
Yeah.
Whereas PPI, if you have heartburn right now, you take that PPI. It's not necessarily going to help with the acid that you're already experiencing right now. It works by inactivating proton pumps. that are, and it works best when it's already active, those pumps.
Mm-hmm.
And so you have to take it, was it half an hour before you actually eat a meal? So you actually absorb it before you eat and those pumps become active.
Mm-hmm. That's because I usually tell patients that that's because when you think about food, usually, like your stomach starts to make more acid now.
True.
Right? It's getting ready to make acid. So you take it to neutralize it. Although, like you said, I usually ask the patient, when are the symptoms worse? Right? They don't actually necessarily have to take it before food. That's from my personal experience. If they said the symptom is worse, like right after eating, sure, take it before that meal, right? You don't even have to take it like at half an hour or time it or whatever. Just take it first and then you eat. That's fine, I think. But sometimes symptoms is worse at nighttime as well, before they go to bed, right? In which case they can just take it and go to bed, and that's fine too, right? I guess that's also like empty stomach, right? So I just tell them it takes usually like half an hour to an hour before it kicks in, right? Like full effect. So they can kind of time it based on like when the symptoms are occurring, right? So that's proton pump inhibitors.
I've also heard that beyond just taking like half an hour, like to an hour for it to take effect, even when you're first starting on it, depending on the severity of your heartburn, it can take like 3 to 5 days for you to see good improvement. Like maybe you start seeing effect, but you won't see full improvement until that time.
If you have consistent heartburn.
If you have consistent heartburn.
It might not actually take, it might take a few days for it to go away.
Yeah. And we'll touch upon this maybe later on as well, but some people take it as a PRN. But I always recommend, if you're taking it as a PRN, it may not necessarily just be that one dose that will do the trick. Maybe you take PRN for 3 to 5 days and then you stop, versus just the one dose there. One-time thing like your antacids.
We can talk about like treatment strategy. Yeah. So that's most of the pharmacological treatment, although you can use like prokinetic agents as well, right? Like domperidone, metoclopramide, and stuff like that. Yeah. Not as common, but you talk about gastroparesis.
The thing with those agents, I don't know, I don't see it as much, unless there's associated like digestion issues, gastroparesis. Yeah. It's more side effects.
There's more side effects.
So dopamine receptors, right?
Yes. So, but one of the classes, if you look at it as well, right? So
should we get into like some of the while we're on that, like side effects, some of the adverse effects with the classes we just mentioned?
Sure. Let's go through side effect and maybe some notable drug interactions.
Like when would you not recommend a certain class, like antacids, for example? We'll start with that.
So beyond,
well, okay, any reason not to recommend antacid?
Any reason not to recommend
rule
antacid?
it out?
There's no reason really to rule out, to be honest with you, except it could aggravate the stuff that they might be experiencing, right? Based on the side effect. Okay. So let's say if it's calcium based, right? So it could cause like bloating, constipation. So if they already have those problems, right? If they're chewing like, I don't know, 10 times a day, so that might actually aggravate the symptoms, right? So same with anything that's aluminum based as well, cause constipation. On the other hand, if you have magnesium based, it would cause diarrhea because magnesium is a laxative, right? So,
Special populations, usually I think of like, because I work in the hospital, we see a lot of chronic kidney disease patients. So
a lot of the ions, right?
Yeah, they may not be able to clear it out as efficiently, including calcium, magnesium, which is a big one.
Yeah.
So I guess that's just one reason why I may not choose that one. But also, like we mentioned, like depending on how they're describing their heartburn, if it's something that's ongoing, like every day they've been experiencing it for the past few days, then I probably just rule it out and go on to the H2RAs or PPIs.
Yeah, because these ones are better if it's just like occasionally
and
they want fast relief kind of thing. They'll be better as well. But because generally the most common one is Tums. Obviously you have like Gaviscon as well. There used to be Maalox as well. I don't think they make them anymore. But anyway, so these ones generally cause like bloating, constipation, or diarrhea. I usually don't like those as much.
Yeah.
Right. So yeah, that's just me. But okay, let's talk about HRA.
HRAs.
So what are the common side effects of HRA? Not that much actually, right? Like maybe headache, just like less than like a few percent. Dizziness maybe a few percent. So that's most of the stuff actually that I've
I think I think it's generally well tolerated. there are some CNS side effects, like you mentioned, dizziness. Most people are okay, but maybe an older adult, like
When they
geriatric
have,
population.
like, that's right, confusion, right?
Yeah.
Whatever. If they get like higher doses, they get dizzy.
Yeah.
It's true. Yeah.
And then I guess we can get into like if you have long-term use. And then when we will talk about PPI's long-term use as well. But there are, I guess,
Tolerance.
reports of tolerance.
Yeah.
Right. So usually like intermittent, like 2 to 4 weeks of use. But I was going to mention vitamin and mineral deficiencies.
Okay.
I think it's what do you think that is?
Oh, you mean like the
Vitamin
long-term
B12,
use?
iron,
Yeah, because
calcium.
you need like acidic environment to actually absorb those things, right? So they're
Now
actually
you're changing it, right?
there are certain things that you actually need acidic environment to absorb. Those are some of them. So B12, calcium as well, and also possibly certain medication, which we should talk about it after the talk about PPI.
Right.
Side effect of PPI, actually quite similar to side effect of H2RA, right? Maybe like headache, dizziness, pretty much that's it, and some abdominal symptoms. But it's actually hard to say when the abdominal symptoms were caused by actually the PPI or H2RA, or whether it was just part of the condition, right? So let's say if they have some like abdominal pain kind of thing, right? Is the pain associated with the heartburn itself, or is it associated with like using H2RA or PPIs? We don't really know. It's hard to tell, right? So I usually like to focus on the side effects that is a little bit more, I guess, like different, you would say, right? So let's say like headache, dizziness and stuff like that, which is not related to the symptoms.
Like, do you mean like if you told them it can cause stomach upset?
Yeah,
Something like that.
But they
And
already
they're
have
like-
stomach upset. To them, this is
Yeah,
stomach
that could be
upset,
confusing.
right? Abdominal
right.
pain, and like I already have that, right? So that's why I'm seeing you.
I feel like PPIs, I don't really talk much about side effects, to be honest. Like in the short term use, it's more like safety monitoring if you're using it for a very long time, like a year or more.
Okay. So now let's
right.
talk about like long-term use then for PPI mainly, but also to a certain extent H2RA as well, because it decreases the stomach acid. Right?
Actually, what is the duration of use you would recommend?
For-
H2RA, for example. Antacids, we're saying you're using PRN, right? It's not something you use every day. H2RAs, we just said that maybe you get tolerance, so maybe 2 to 4 weeks at a time. What about PPIs?
So generally speaking, so if you're making a recommendation without prescription, right? So I usually say approximately 2 to 4 weeks, usually 2 weeks or so, right?
That's the
reason is
packaging,
because-
right? 14 days.
And I think that's also common sense as well. Like, because if you take it for 2 weeks and it's not working, you should go see a doctor.
I could just buy another package.
That's true, but there might be something more serious going on,
Right.
right? Could be structural damage, like you don't know what's going on.
We need to let them know that, right?
Exactly. So actually for a lot of the counseling, I don't know if we actually mentioned in our counseling episode, right? It's almost like common sense dictated, right? Like how long do you use this medication for? Like if
Common sense
have
to you.
if I have to take this
But
medication,
I mean, not
like for
common
me-
sense to them.
No, exactly. That's why you have to teach them.
Okay.
Like
Your common sense.
exactly my common sense,
Right.
right? So because we know about the medication, they don't, right? So
We're the
if-
experts.
Exactly. So if you were
Listen
to
to
take,
us.
if you were to take this H2RA or PPI, when would you say, you know what, I need to go see a doctor? 2 weeks usually, right? If you take it for 1 to 2 weeks, honestly, even 1 week, if there's no improvement at all, right? Wouldn't you want to go see a doctor? At least book an appointment.
Part of it's denial. You know, maybe if I go check this, maybe it's going to say something's wrong, really wrong with me. Whereas if I just keep taking this pill that's been working, then I don't need to know all that other information.
That's right.
But like you said, it is common sense, right?
Yeah, common sense to us because we have the
To us,
medication
yeah.
information, right?
Yeah.
So,
but to the patient, like they're in a different headspace there.
and also they might not know. They might think that I can continuously take it and eventually it will go away, which is reasonable if you don't have the knowledge, right?
Plus, it's more convenient just to come to you than book an appointment with the doctor. And I'm sitting in the waiting room for hours.
Although now you can get minor ailment prescribed.
Oh, yes.
So that's right.
That's right. Exactly.
Although they can just buy Nexium again.
But that would be inappropriate, right? We should refer at that point.
Yes.
Yeah.
Right. So.
Or we can prescribe and bill.
And Bill, that's
No,
right.
I'm just kidding. No, that would be unethical.
And we talked about what
We should
were
do
talking
that.
about?
Did we do an episode on minor ailments actually?
We have not done the minor ailment.
What happened? Yeah, we should do an episode on minor ailments.
But aren't we doing every single topic one by one now in minor ailments, pretty much?
But I mean, like the process.
Oh, the
of it, yeah.
process. Okay.
It's
I don't
probably
really-
because
I don't
we
really
both
do
don't
that
do
much,
it.
though.
Yeah,
We
that's
don't do
right.
it that
Yeah.
much,
I'm in the
very
hospital
rarely. Yeah, very
where we
rarely.
don't, there's an emerge there. There's doctors there already. You're going to see your doctor or go to emerge. if it's even-
And I work next to a clinic, right? Which they do most of the prescribing.
Right.
Like, why am I prescribing and taking away their business?
So we're probably not the best experts to ask about the process and billing.
That's right. We should invite some corporate pharmacists to come out and and talk about that. They are the expert because they have to do like 10 a day or something like that, right?
What's the quota?
I don't
Oh,
know
not
exactly.
quota. No, what do you call them now? Targets?
Targets.
Targets.
Do they call it targets?
Professional targets?
I don't know.
I don't know.
Well,
But if you want to keep your job, you got to meet those numbers. That's all I know. Okay, we shouldn't go too far down that rabbit hole. Okay, let's get back to our topic here.
so we talked about long term.
PPIs.
We are talking about long term effects, right? So before we just finished talking about like referral, like when would you refer them, right? So basically not working after a couple of weeks. So what are the long term effects of taking H2RAs or PPIs, right? So you talk about nutritional deficiencies, right? Vitamin B12, because you actually need stomach acid to absorb vitamin B12. So if you take it for a long time, you reduce stomach acid in a chronic, I guess, manner, right? So you will actually have possibly vitamin B12 deficiency, right? The other one is osteoporosis, right? I think calcium also, the absorption
Right.
also requires stomach acid as well. So that's pretty much
Gastricity, yeah.
exactly. So that's the
Iron?
the reason. Iron, okay, yeah.
Depending
So-
on the type of iron. Iron salts.
So that's why if you talk about like osteoporosis, or may not be that extreme, right? But bone health in general, right, would reduce if you actually take it for a long time, right? So there's another one actually. So if you actually take basically reduce stomach acid for a long time, take these medications, right? There's higher risk of infection as well, possibly, right?
C. diff.
C. diff, correct? Yes. And because gastric acid is effective in, I guess, defending whatever is coming in as well, right? So reducing that could cause some adverse outcomes, I guess, right? C. diff is one of them.
Pneumonia, I've read.
Pneumonia too, possibly. That's right.
You're right. Like you never think about, well, previously they never really thought about that. I guess when PPIs first came out, it was like, oh, look at this wonder drug. It works. It's much better than whatever options that are out there right now. Just take it once a day. Just keep taking it forever. Right?
That's true.
Why do you need acid around?
So
you
along
only need
the-
acid just for digestion, but now they know.
Yeah, a lot of the information didn't even exist when we were in school, I think.
No,
Right?
we
We're just
never
talking
learned
about,
that.
yeah, we didn't even talk about that. And then I was reading some of the newer things and saying that like how vitamin deficiency and stuff like that. And I was like, that does make sense, right? So all these evidence actually came out in the past 10 years, right? Because it wasn't there when we were in school like 15, 20 years ago. So they're all coming out in the past 10 years.
It's all about lifelong learning, right?
It's true. So that's what we're about, right? Lifelong learning.
That's stressful.
That's okay. Don't worry. There is a pill for that. So there's your Nexium.
Well, school taught me that I just memorize whatever's in that book and I'm good.
That's right. So
They never told me real life is so stressful. Things can change at a dime.
It's actually very different than textbook, right? I would say most of the stuff I learned in practice
You mean the book we studied like over a decade ago?
over a decade ago. That's right. Most of the stuff I learned is actually learned in practice, I say.
Yeah, it's
right?
true.
So I don't know if we mentioned that before. We should do an episode on that as well.
What?
Lifelong learning.
Lifelong learning?
Yeah. So
Like what
are the,
what we do.
where are the places that you
Strategies.
should go and learn exactly?
Right.
Like how do you keep up to date with stuff?
Yeah.
And things like that. Okay. So we talk about all those pretty much the side effect and stuff like that. And we briefly mentioned the prokinetic agents have more side effect, right? The metoclopramide, domperidone, because of the dopamine as well.
On this topic of gastric acidity, though, so other than helping us defend against foreign bacteria, helping us absorb vitamin and minerals, you mentioned interactions as well. What comes to mind? Well, iron, mentioned that one, but what other medications require?
Like require acidic environment.
Yeah. So one big one, clopidogrel.
Clopidogrel, okay.
Actually, I'm not sure if that's an acidic environment, but it does interact with a lot of the PPIs. Actually, that might be a SIP interaction. Now
Yeah.
that I'm thinking about it.
Yeah, it is the.
But I always think about
2C19.
clopidogrel when I see a PPI.
Mhm.
So omeprazole, esomeprazole. I think we did learn this one in school as well.
Mhm.
And that's actually a major interaction, right? If it does occur. I mean, someone's on clopidogrel for antiplatelet efficacy. If you're not having good effects on that, you might have an event.
So we're talking about drug interactions now.
Yeah.
Okay, that's all drug interaction. We have a question actually.
Oh, we do?
On the chat. Yeah.
Okay.
So
Let's see. For patients on long-term, so here's the comment. For patients on long-term PPI therapy, do you recommend tapering off the medication when they are planning to stop the medication? Okay, yeah, we can talk about deprescribing after as well. Okay, so good question.
yeah.
We will get to that. Okay, so but back to the interactions. Any other?
Well, let's talk about interaction then. Okay.
Yeah,
So,
and then we'll go to deprescribing after this.
sure, let's do that. So interaction, if we even talk about interaction, we can even start with antacids, right? So like all the calcium, calcium carbonate, magnesium, and like aluminum and stuff like that. So they interact with common class of medication, antibiotics, right? Tetracyclines, fluoroquinolones,
Antifungals,
antifungal. It's a different one as well.
like itraconazole, ketoconazole. I've seen
Yeah.
that as well.
Because they require acidic environment to be
Right,
absorbed,
right.
right? So the absorption of like the antibiotics sometimes, if you have antacid, it could actually impair them, just bind together. They don't really absorb, right? So tetracycline, fluoroquinolone, and stuff like that. Iron supplement you talk about, bisphosphonate as well, obviously. It's very sensitive to food. Also synthroids, right? The levothyroxines.
Right.
So
That's a good one.
they're
Basically,
all
we're thinking about what do we tell patients to take on an empty stomach?
That's right. It's true. So, but certain ones, right, interact with these like ions and stuff like that, right? Like tetracycline, fluoroquinolone. You don't have to take those on empty stomach, right? But depending on the tetracycline, I guess. But they do interact with the calcium and the magnesium and stuff like that. H2RA decreased acidic environment, we talk about as well. So you talk about ketoconazole, itraconazole. There's a very rare H2RA. I don't really think we use anymore, cimetidine,
Oh yes,
right?
lots of interactions with that one.
Tons
That's
of
the issue,
interaction.
right?
Yes, because it inhibits CYP.
I think it also has more CNS effects, so it's fallen out of favor. I
That's
haven't
right.
seen that in ages, but we used to see that. Do you still see it?
I still see it. Oh,
It
very
still
rarely.
exists?
No. I had one patient who tried
Oh,
for
wow.
a while. Yeah. So, so that's H2RA as well. PPIs we talk about, also anything that requires acidic environment, right? So we talk about calcium, antifungals as well, right? And some of the irons possibly. And the interaction you talk about was omeprazole, right? Like CYP2C19, I think.
Oh, good
which
memory.
will,
Is that right?
yeah,
2C19?
I think it's 2C19.
Yeah.
So which will affect clopidogrel and anything else that's like through that pathway. I think phenytoin as well. So
It inhibits it, right?
inhibits 2C19, yeah.
And clopidogrel, it's a prodrug. That's why. Right, we'll get
That's
to it.
right.
Got a question here. Can we crush the tablet, or is there a liquid formulation? Oh, that's a good question.
Of which
PPIs.
all PPIs? We can go through all of them, yeah.
PPIs are actually, they're specially coated. So you cannot crush them.
So we should talk about it when we talk about pediatrics as well, actually. So the options for pediatrics patient.
Yeah. Should we talk about deprescribing first, and then we can talk about the formulations?
Yeah, that's all about pretty much the interaction, right? And obviously, if you want to go more in depth, then there's more interaction with the prokinetic agents as well. But we don't really see that much, right? QT prolongation and things, but we don't really see it used for heartburn as much. So, yeah, let's talk about deprescribing then.
Like if someone's on a PPI for years,
How do
and
you
then
get
now
off?
we know that there are issues with long-term PPI. So now
Yeah.
how do we get them off of it?
Yeah.
So I think there's a number of different strategies, right? Well, I guess first of all, we have to assess, is it appropriate for them to come off of it, or is there an indication for them to continue it?
That's right.
Common indications, I looked this up, Barrett's esophagus, erosive esophagitis, history of GI bleeding from peptic ulcers. Basically asking them, have you been told by a doctor exactly why you're taking this? And if you have like Barrett's esophagus or like something so specific, you would know that. Versus like if they say, I don't know, I just started years ago because I had some heartburn. Then I would say, okay, well, there doesn't seem like there is an ongoing indication,
Mhm.
then we can consider a deprescribing strategy.
Mm-hmm. So how do you actually deprescribe then? So let's say they don't really know why they're taking this for the past year because the heartburn improved already, right?
Mm-hmm.
So why are they still on this medication?
Yep.
Right? So let's say if you decide maybe it's a good idea for you to actually start to cut back a little bit, how would they actually cut back, right?
So I've read that if you actually just stop,
Mm-hmm.
like anything, I guess, like your body's used to having that thing around.
You get rebound symptoms.
You're gonna get rebound. I guess hyperacidity. So it's probably a good idea to taper gradually. There's actually algorithms out there like deprescribe.org, which I haven't really reviewed, but I think you just taper gradually over probably a course of months, like 48 weeks,
Mm-hmm.
might be reasonable. In the meantime, monitoring for any signs of rebound heartburn symptoms.
That's right. So I would actually I haven't read any of the tapering guidelines, but it depends on what medication you're talking about, right? So in this case, I would use what I call like my common sense tapering,
Mm-hmm.
right? So let's say if you're taking 7 days a week, right?
Mm-hmm.
Can you cut it back to, let's say, like the less stressful times, right? Maybe the weekend if you're not working. Try not to take it on the weekend, right?
Mm-hmm.
And take it like 5 days a week and see if it works, right?
Mm-hmm.
If you have no heartburn, just maintain 5 days a week,
Mm-hmm.
right? And then let's cut it back maybe 4 days a week. Does it actually work for you,
Mm-hmm.
right? So once you have heartburn symptoms, then maybe stop there and then continue like coast for a while and see if the heartburn symptoms go away first,
Yep.
right? I also tell them to actually talk to the doctor as well, right? Inform the doctor, at least, I'm doing this. Or like my pharmacist recommended maybe tapering off the medication, right? Instead of just saying, oh, just go to the doctor and ask the doctor, right? I give them a plan and tell them, you know what, go discuss this with your doctor. This is what my pharmacist said.
The doctor's
Right.
busy.
Doctors are busy. It's like family doctor. No, like at least notify
I
the
can
doctor.
just walk in the door and ask you though.
It's true. That's my recommendation. But you should notify your doctor that you're tapering off the medication.
Can't
That's
you
what
tell
I'm
my
saying.
doctor for me?
If you want to, sure. Right. So what if it's like non-prescription?
That's a good point.
That doctor should know too, right?
Yes.
I just think that a doctor deserves to know. Sometimes
They
like,
deserve
things
to know
that's
what's going on with you. Yeah.
the patient, right? Of
Yeah.
course, I can tell you how to taper, right? But your doctor is under the impression that you're taking this medication,
Yeah.
right?
Yeah.
So, and who knows how many days you're taking in a week after like a couple of weeks or 3 weeks, 4 weeks, right?
Just because your doctor ignores you or charges you
No, you book an
for
appointment. Like, does your doctor charge for appointment? I don't know. I don't think they charge for appointment. So depends on like I guess like what if you have
well, now you gotta take time of your day, right?
That's
Just because they do all that, but us pharmacists, we're right here. You can just walk in and ask us. Just because we're nicer doesn't mean the doctor doesn't deserve to know.
it's true.
I was trying to get
So-
at, yeah.
So that's actually just deprescribing kind of our strategy. Did it actually answer, I guess, your question?
I guess if you're tapering, like how would you taper, right? I guess some people, it depends on how they're taking PPI right now. I've seen like twice a day dosing. Like you mentioned, maybe they have some nocturnal symptoms. And if once a day dosing in the morning is not enough, you switch from twice a day maybe to once a day dosing.
Yeah,
You
And-
do that for a couple of weeks.
that's right.
And if you're at once a day, you switch to every other day,
Yeah,
which
that's
makes
right.
sense. And then maybe after that, on demand use.
Yeah, and sometimes from twice a day, you don't even have to go once a day every single day, right? Like I said, right? Maybe once a day on the less stressful day for you, or like the symptoms less likely to occur on certain days, right? Then go from there, right? So maybe I take it twice a day for like 3 days of the week, once a day, 4 days of the week.
Yeah.
That's decreasing, right? That's a good sign, right? It's kind of like smoking or anything when you're trying to get off. You don't have to go completely cold turkey to zero, right? Your goal is zero, but some patients never get to that goal. Some patients are just down to maybe like PPI 3 times a week. That might be it, right? So there's a lot of individual variability as well, which they don't teach you in school because all of us are different, right? I'm happy with like 3 times a week, right? It's much better than like 14 pills a week, right? I'm taking 3. So
If the concern is like, okay, I really don't want to be on this PPI because you're scaring me with all these risks that can occur to my bones, getting C. diff, getting pneumonia, then we can go back to our other therapies, right?
that's right.
So, okay, maybe if it's just intermittent heartburn once in a while,
You
H2RAs,
can even
tests.
try to decrease the PPI and try to use Tums PRN, right? Try
In
to
between.
control it a little bit.
Yeah,
Exactly.
yeah.
Yeah. So, all right. So that's deprescribing. Very good topic, actually. So
The other question was, can we crush a tablet or is there a liquid formulation? So should we talk about
pediatrics then? Let's talk pediatrics.
Special populations?
Yeah. So special population, there are like basically 3 types, right? Usually
I
geriatrics,
don't deal
pediatrics,
with pediatrics,
pregnancy.
though.
What?
Sorry, go ahead.
So you thought you don't deal with
I don't see a lot of kids. Do you?
like kind of here and there, right?
Well, your clinic would, right? Like it's a family family practice clinic.
So interestingly, for kids, a lot of times like younger kids I'm talking about, right? If they're older, they can probably take like H2RA and stuff like that. But for younger kids like babies, right? They usually take PPIs actually, right?
I haven't, because I don't see a lot of pediatric population. I think I've seen like PPIs, but compounded
So we can actually talk about like different class, right?
or
So
ODTs. Yeah.
the antacid usually I think it's for 6+, right? I might have to look up like the actual number, but 6+ I would recommend. I could recommend using antacid. H2RA a little bit younger. I've seen like younger kids use it as well because there was the liquid, right? I think they stopped making it, right? Ranitidine liquid.
The only one I see, I haven't seen H2RA liquid
in a long time.
but we have like compounded PPI liquid.
Compounded PPI
like
liquid, that's
omeprazole.
right. Yeah. So the most common one is actually omeprazole, right? For kids like infants. Although they can also use, the only one that's commercially available is actually lansoprazole, Previs fast tabs, right? You can actually dissolve it. You can probably cut in half as well if you want. I've seen babies use that as well, just because it's most commercially available. But you're right, omeprazole is the one that they actually prescribe a lot for babies.
Maybe there's more evidence for that.
Yeah, there's more evidence for that. So
if you have someone who can, like, babies or someone who can't swallow a tablet whole, whatever reason, we have options then, right? Can you crush those PPI tablets? From what I understand, you should not crush them because they're enteric-coated. I'm not sure if certain capsules you can maybe open it, but even those beads, you're not supposed to crush it.
Yeah.
But we have options such as oral disintegrating tablets, or your other option would be compounding a mixture with PPI liquid formulation. If you can't swallow whole,
they use it. They use a tablet. So actually, not tablet. The powder. They use powder to actually make the compound. And I know in theory you could actually break down the tablet and try to make a compound out of this, right? But recommending patients doing that is probably not a good idea, just because if you actually break the tablet, it's not as stable, right? So when they actually make the compound, they don't actually just put the powder in and add water kind of thing and shake or whatever. They actually have all these other stuff to balance the pH, balance the stability, right? So just crushing a tablet and like add all these things to it might not actually work very well, although you're getting the same chemical probably.
That's why PPIs are coated, right? Because it has to be protected against the stomach acid first before it gets absorbed. But if that protection is gone, it's just going to get, by the time it gets to your intestine, it's going to be disintegrated.
Well,
yeah,
that's right. So that's what I would say, right? I mean, is it wrong if you have no options? I guess you can crush them, but ideally you probably won't want to do that because it's not quite as effective. Although I've heard that so Medisca actually makes this powder. It's actually very easy. If you want
some guy makes a powder?
No, Medisca.
Oh, Medisca.
Medisca actually has a commercially available
I thought you said
powder.
this guy. Who's this guy?
This guy, Medisca. Medisca actually has a powder where you can actually just add liquid, I think.
It's a PPI powder?
Yeah, I think so.
No way.
It's very easy to compound, apparently,
really?
I think. Yeah. I need to look it up a little bit more.
So, I guess it's worth it, like if you have a lot of prescriptions or that patient population, right?
And the other thing is powder, probably you can store it on the shelf for quite a while as well, right? So even if you just have like powder, like the bottle here, imagine if it's like, I wonder if it's like amoxicillin powder. You can mix like so easily. That might be worth carrying. Anyway.
Why are kids getting GERD?
They have like erosion, right? No. In the esophagus.
You think they're just like, maybe they're
they call it like what?
Just immature systems that can't regulate
esophagitis or whatever.
Yeah.
Right. Yeah. They have that. I've seen babies take omeprazole for a while, and then usually it goes away. I think. Right. So maybe the sphincter is not working. I'm not really sure. Right. So I'm not a specialist on like GI. So, but kids do take this. Yes.
What other special population you mentioned? Pregnancy.
Pregnancy and breastfeeding. Okay. So yeah, pregnancy is one of the like I guess risk factor, right?
We already mentioned why that could be.
That's right.
Baby's there pushing up
That's right.
on the
So
stomach.
first line usually is actually Tums, right? So calcium carbonate,
Antacids.
antacids. That's right. Because PRN used a lot of times.
Yeah,
So-
calcium, not a bad idea to supplement with as well during pregnancy.
That's right.
Um,
Although they can also use H2RA,
mhm.
right? Generally is safe for pregnancy and breastfeeding.
Most evidence with famotidine and ranitidine.
Familiar
If
ranitidine.
ranitidine is still around.
If ranitidine does not cause cancer, then yes. But right now, obviously, famotidine mainly, right? They can also get prescribed ranitidine. I've seen that too.
Can I go straight to PPIs?
Then we can go to PPIs. PPIs are generally safe, right?
Is one more safe than the other?
I think most of
What
the
you read?
evidence is with omeprazole and pantoprazole,
I think that's why I usually see prescribed.
right? So, and I'll also say probably because they're not very expensive, right? Personally, I like pantoprazole. I like rabeprazole as well. I think it works quite well. It's not very expensive, reasonable. I'm not talking about just for pregnancy, but in general, right? But omeprazole and pantoprazole are the ones that usually use for pregnancy a little bit more, right? That's
Yeah. I think in
Most
terms
of
of safety data, antacids, like you said, so we usually start with that.
yeah.
Then maybe add or switch to H2RA and
Yeah.
move on to PPI.
That's right.
Right.
So yeah, I've seen omeprazole more in pregnancy actually, but pantoprazole apparently is also safe. So
What would you avoid in pregnancy?
in pregnancy,
Just anything that comes to mind?
not necessarily avoid any of them, but like I would recommend these ones over the other PPIs. I guess it's just because
More evidence.
right? It doesn't mean that the other ones are harmful, right? It's like if they try omeprazole, they try pantoprazole, it doesn't work. Doesn't mean that lansoprazole is going to be harmful. I don't think so, right? It's just that it's not as much evidence to support the use, right? Doesn't mean that they cannot use it. It's PPI, it's the same class of medication, right? So let's say if you're able to use omeprazole, don't you think esomeprazole is probably okay as well? It's just newer, haven't been studied yet. So
How about breastfeeding?
breastfeeding pretty much similar to pregnancy. Did you find anything like different?
I guess oftentimes when I'm thinking breastfeeding, like from the mother's standpoint, if it was safe in pregnancy, it should be safe for her in breastfeeding. But we're thinking about the infant now, right? I think I found that from my research, it's the same recommendations, starting with antacids, H2RAs, relatively safe. PPI is generally safe. Only a small amount passes into the breast milk, but is also unlikely to be absorbed by the infant. So, but prokinetics actually,
Prokinetic
the
agents?
metoclopramide that we mentioned earlier,
Like for pregnancy and breastfeeding?
because breastfeeding, like those can help stimulate your milk production, right? Is that okay?
Yeah. Yeah.
Two birds with one stone.
That's fine.
Yeah.
So usually in that case,
If it's associated with baby, they're
yeah,
thinking,
and although they would usually try this after they've tried the other ones
right.
first, right? If the other ones don't work, sure, why not?
Like if you have associated like nausea along with it,
Yeah.
that could be a sign that you're not digesting, your motility is not moving well, right? Geriatrics.
Geriatrics, sure. Let's go geriatrics then.
We mentioned one, H2RAs. Be careful of those, right? Older adults maybe more susceptible to the CNS effects. Maybe those PPIs. We don't want you to have brittle bones.
You also mentioned that the renal condition as well, right?
Okay. Yeah. As you age, everything declines. I know you said it sounds depressing, but
We're not there yet, so it's okay. We still have some time.
right.
So we have another question on the chat as well, actually.
Yes.
Our opinion on bismuth,
Oh,
on GERD.
it's not one that I see. It's not one that I recommend very often. Is there a particular reason why? I'm not sure. Let me think about that.
So, in the commercials, right, they talk about Pepto-Bismol, which is bismuth, right? Nausea, hyper indigestion, whatever, upset stomach, diarrhea. Like that's like their
Like when you read the
right?
bottle, it advertises for like what 5 things, right?
Exactly. The commercial. So the thing I would say about bismuth is that bismuth is good for like a little bit of everything, right? But it doesn't really treat anything in particular.
Right.
So that's actually how I recommend it as well.
Yeah.
If you have like non-specific symptoms, right, then you can take Pepto-Bismol, considering allergies, right? Obviously, if you're not allergic to aspirin, then that's okay.
That's the other thing, right? There's like more, okay, so yeah, efficacy standpoint, they're advertising for like these 5 indications.
But they're
like
not
you said,
particular for anyone.
particular for anyone. And then now a safety standpoint, if you have like a salicylate allergy, what else? Like pregnancy, can you take salicylates?
No.
Not in all trimesters, right? I think, yeah. So it never really crosses my mind.
Not in
on my
kids
radar
as
there.
well, right? So,
Right. Yeah.
yeah.
Risk of Ray's syndrome.
yeah, exactly.
Yeah.
So that's how I would actually recommend Pepto-Bismol in general. Although it seems to work better for diarrhea, like of all the 5 symptoms, right? But it does treat a little bit of everything, right? But not specific enough. If you come in and tell me that you have heartburn, that's not something that I would actually recommend. But if you said, oh, I have a little bit of everything, can I try this? Sure, go ahead. If you are not allergic to aspirin, that's how I actually look at Pepto-Bismol. I don't know.
It has these wacky side effects too, right? Like black hairy tongue.
All these like random things, right? So that's okay.
Imagine telling a patient that.
If you don't want to take them, if you don't want them to take it, then just put all these
Start
scary
with that.
side
Start with
effects.
that.
Exactly. Your tongue will be black, right?
You're recommending all these other things. They're like, what about this pink solution here that I've seen on TV and all over the internet, and I hear about it from my grandma. They say this one's the best.
That's exactly my recommendation. This is good a little bit for everything, right? But it doesn't treat anything in particular that's like specific, right? So, I mean, if you know that it's heartburn, then you probably should take something a little bit better for heartburn.
I think the only time I see Pepto-Bismol is really like in the context of what H. pylori treatment.
H. pylori treatment, that's
But
right.
we never really actively like recommend it, right? Yeah, for all those reasons.
But even in H.
stated.
pylori treatment, it's not the main one to decrease stomach acid, right? It's the PPI
That's what
that's
the
decreasing
PPI.
stomach acid, exactly. So, yeah. So does it answer your question? I guess.
Yeah. What else is there? We've gone about an hour now.
Yeah, so I think that's
Plus-
pretty much most of the stuff. We talk about risk factor, we talk about medication, we talk about side effect,
Let's ask the
interaction.
chat. See,
And-
you guys have any more questions?
Yeah,
And
any
pose
more
them now.
question about GERD, or are we okay for now?
For our listeners on Spotify who are not listening live, you can reach out to us through Reddit as well as X, or shoot us an email directly, pharmacyunplugged@gmail.com as well.
That's right. So that's good, right? So if you guys can join us in the future, come by and say hi. We are here every other Friday, 9 p.m. Any topics that interest you in the future, you can also message us or send us an email or let us know. We usually will check them, usually.
Go to our website. There's a link to our YouTube, and it will show our next live show date as well as a topic. Usually the topic we won't have posted yet until maybe 3 or 4 days in advance, so you can check back then.
But if you guys have any suggestion for future topics, feel free to actually add it in. We have a list of topics. We'll just add to those as well. And we love interacting with you guys. So make sure you guys come and interact with us. So hopefully this episode has been good for you guys. If you guys have any further question or comments, feel free to reach us. Anything else?
No.
That's
Let's
it,
go to
right? That's all the time that we have then for this episode. Until next time, have a good week.
She is? Oh, I thought that started. Sergeant the whole time. I'm like, accent harder. It must be like a pseudonym.
Access my first.
Like right now. Wow, she's such a good student. Coming in on Friday night. Awesome. How did you move on with friends? Oh, that's what we should say. Like and subscribe. Oh, we forgot that too. Subscribe to our YouTube channel. I thought that went well. It is a little bit different in that there's questions that come up that kind of not really throw us off, but you know, like we have like a logo, right? But we have to sidetrack now and then address like comments. But it's also good talk about this part. All right, so this